This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.
Today's episode, we're following up on what Justine and I have been talking about over, a whole ton of time. And the main thing, the main part within that is about how we discuss expectations for patients. And so a lot of the time we have a set of patients that will come in looking maybe for a magic bullet, or actually maybe the other way around, where, we've tried something and it hasn't worked and they get frustrated by that, and sometimes they blame themselves, and it's like that's just not the way it is. And so what we have is we have what's called therapeutic limitations. So not everything works for everybody, basically, and there will be a subset of people that you will treat that will get 90% pain relief when you use something, and then you'll get another set of patients that you use exactly the same drug or same therapy or same intervention or same whatever, and it makes them worse. And how do you pull out the difference between that, and how does that then represent itself within the scientific literature? The concept there is number needed to treat. So far we've talked about a systematic review that has reviewed essentially exercise, medications like duloxetine, anti-inflammatories, cortisone, a couple of others. The other major thing within pain is then pain neuroscience. And so we want to look at what is the effect or the number needed to treat to be able to have a significant effect in those patients. Now, I don't have a paper that gives us the number needed to treat. However, there was a systematic review done in 2016 by Adrian. I'm going to go low. I'm sorry if I've just pronounced your name incorrectly, Adrian. I'm going to share the screen here so we can get a bit of an idea of what it looks like. So it's titled Efficacy of Pain Neuroscience Education on Musculoskeletal Pain, Systematic Review of the Literature. So we're not going to break this down because this is a pretty solid paper to read, and they don't have a whole stack of diagrammatic format for us to look at, unfortunately. But of course, with pain neuroscience, you really want to look at, does it affect the patient's pain, and is it affecting the psychosocial factors? So the psychosocial factors, and what they've done here, and then they've broken it down, they've done it in paragraphs, which is like really, really hard to read. They've looked at a whole bunch of different studies, and they've looked and they've described in each one of these studies how much of a difference has taken place for each one of these things. And they've also described whether it's statistically significant. So number one up on that left-hand corner is the SOPA score. So it's a survey of pain attitudes. That would be that you'd expect that if you're getting a change in attitudes toward pain, as you would expect with pain neuroscience education, that should be one of your primary aims that you get. And so you can see within this that, and the other little thing there you might be able to see is called the PCS, that's pain catastrophization score. And you can see based on the P score, for those people who are wondering what P is a measure of how significant it is statistically. And they've shown that it's less than 0.05, it's 0.001, which means it's actually very significant. So it's statistically very significant that with pain neuroscience, you get an improvement in attitudes towards pain and pain catastrophizing. Now, how much is that clinically? So when we then go across and we look at the original study, so this is done by Mosley, Michael Nichols, and Paul Hodges. I know Paul.
Yeah, these are big names in the pain science space.
From sitting around after conferences having a beer or two. He's a lovely chap. So I'm going to swip over to the original paper that comes from. So this original paper.
And these results might surprise you a little bit, where something can certainly be statistically significant, but what does that actually translate to in a patient's quality of life, for example?
So what you've got here is you've got a diagram of that study we were just referring to out of the systematic review. This was done in 2004. It's one of the original studies. And you can see a line, and you've then to the right of that line is a positive improvement. So that is a percentage change in the results from the intervention. And so they had two interventions here. First intervention was pain science education, and then the second intervention was a back pain education. And so on this scale, the ones that are black are the back pain education, and the ones that are white are the pain education. And so we referred before to the SOPA score, which is the survey of pain attitudes. And so what you can see here is that the SOPA score, which change out of 10. So the patients that had the back pain education, looking at this, down the bottom is 0% change. And you look at where they are, they've had essentially no change in their attitude towards their pain. If you then look at the pain education change, yes, they've had a greater than zero change, but this is where we get down. Now, is this the bit here and the bit here? Yes, they are statistically significantly different. All right. If you then come down and look at what the change is, we're talking they've had like 15 to 20% change in attitudes across the group. That's not a big change in pain.
Yeah, Dana, not even 20% of output of pain, but just that attitude component differing.
Yeah. And so once again, this is another therapy that's not the be all and end all. It's not the magic bullet. For the main thing that I would think would change, which is the patient's attitude towards the pain, on average, it shifts that attitude 15 to 20% based on this score. The other question then is, everyone will go, and I think a lot of people, when they go, I'm going to go to a pain program and what's going to happen, my pain's going to get better, because it says pain program and you would expect that your pain would get better. So if you look down the bottom of this scale and you look at VAS, so that's visual analog scale, and it is looking at, that's when like people like me ask you, what's your pain out of 10? Does it change? And you can see if you look at it, no, it doesn't change. No. And so what we've got to understand is that we can use these tools to improve components of pain. So yes, you can improve attitudes. Yes, you can improve emotional status. Yes, you can improve anxiety and depression and stress. But is it the be all and end all? No, it's not. And what I would think we would probably find is that if you actually had a patient that had severe anxiety and you implement these strategies, what you actually see is they'll probably get a better result because you address directly their anxiety. And for the person that has got, who catastrophizes, which is the P, and has got terrible attitudes towards pain, yes, well, they're the ones that are going to be up at this 20, 25% improvement in their symptoms. Or, if you can shift somebody, their pain catastrophizing by 30%, that actually becomes relatively significant. So it's, once again, just like we discussed previously, it's about picking what you use your pain for, like what you use your intervention for.
Right. And someone who's disproportionately affected by those components of pain is going to have a disproportionately positive, compared to the average person, response to those type of things, which actually makes sense, because if someone's pain was dramatically improved, let alone completely eliminated by pain programs or pain science in and of itself, it would prove that pain is in patient's head, but it doesn't go away completely, because it's not, right? That's an aspect of pain. That's a amplifier in and of itself. And you can argue in certain disease processes and with certain patient populations, like in my work with complex regional pain syndrome patients in particular.
Of course, a lot of the programs that we send people to are called pain programs. I think the expectation that gets set is that it's going to shift your pain. But if you look down the bottom here, you can see that this is VAS. So VAS is a visual analog scale. It's the thing that I ask patients annoyingly, what's their pain out of 10?
We all hate this.
Everyone hates it. Like, I can't even do it when I get asked, which is interesting. But what you can see is that it doesn't change. And so once again, you got to have an expectation. What are these things going to fix? These things are going to get some improvement with attitudes towards pain. Is it going to be all of a sudden people think that pain's, now completely in their head? Well, no, like clearly they don't. And it doesn't change attitudes towards pain that much, which I think is like fascinating.
Yeah. Well, the fact that it doesn't even change the attitudes towards pain as much, let alone the output of pain. And that's why you could argue with people whom anxiety or, the sympathetic overdrive is a big piece of their pain, or the lack of understanding around how pain works if it's a disproportionate piece of their pain and disproportionately amplifying their underlying symptoms compared to somebody else, they're going to have a better outcome and be more towards the right of that graph. But for the vast majority of people, it's not necessarily making a big impact, which actually makes a ton of sense because chronic pain isn't in your head. Your mindset, your perspective, again, with certain disease processes, with certain populations, it has a disproportionate effect. But if it was actually in your head the way pain science and the biopsychosocial model sort of projects, you would see much better outcomes and you would see way larger percentages of pain changed, let alone just the attitude component. Because I do think there is power in understanding what's happening to your body. I certainly see that in patients I work with as we can start to tease apart their pain and they can see the full picture and, remove the fear of, I don't know what's happening to me and why. That matters. Is it 100% of your pain? No. Is it 50? No. It starts to allow you to just deal with it, which is the point. And if you got 20% improvement from stimulators or from medications, you would not be super pumped about that. So to say that just teaching people pain science, is going to have this incredible impact, it's not really fair. And so when you then go into pain programs with that expectation, you're left pretty disappointed. And when you actually know what the number needed to treat is, right, or what aspect, even more importantly, I'd argue, what aspect of pain are you treating with that intervention or that therapy, then you can match your expectations appropriately. Oh, I went to a pain program. Oh, I worked with Justine. Oh, I, did these certain things to get a grip on certain things that I could control versus things I couldn't. Where might that put me? But it's not the magic bullet, like Dan was talking about at the beginning of this episode. No one thing is, including pain science in and of itself, which is why we want to teach it in a more nuanced way.
You've alluded to, which I think then ties in with the evidence discussion. We've already discussed that the application of group data to the individual is illogical. Okay, so unfortunately, the basis of how we do medicine in that scientific fashion is like, it's got its own name, as we've already said, which is called the ecological fallacy. And so how do you actually get around that? What Justine's alluding to is essentially three things, which ties in with evidence-based medicine, which is the use of the best available evidence. Okay.
Yeah.
It's then the experience of the clinician and it's the wishes and desires of the patient. Now, that is actually what evidence-based medicine is. Back in the day, when a lot of the discussions around evidence-based medicine, not really starting, but they were really getting solidified. So David Sackett was one of the original authors. And in 1996, so I'll just read his description. So evidence-based medicine, what it is and what it isn't, published in 1996. Basically, he defined it as the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. Okay, it's a wordy thing, but
is that why you were looking up judicious, Dan?
yeah. Because I was wanting to get the exact, because judicious
What
gets
a great
used in
example of a bad
different
definition.
frames, and I thought, what does he actually mean in this setting? And so judicious is making a considered decision, basically. It's actually thinking about what you do. And so if you take those things, it's conscientious, so you're actually, making an effort to look at what is the best evidence, using it explicitly, so it's, relative to that problem. And it's judicious. It's, you got to think about it. You can't just go, oh yeah, that's what Cochrane Review says, I will do that for this patient.
Right.
It's not the way it works.
Evidence-based is more than just applying the group data. That's what you're saying, right, Dan?
And the last piece within that, he uses the words individual patients. And so you've got to actually work through it and apply it to the individual, which means you can't apply just the group data without thinking. Over a couple of years, that definition then changed. And it then moved to, in quotes, a more recent definition describes evidence-based medicine as healthcare in which treatment decisions are based on the best available knowledge from the clinical research, makes sense, the experience of the doctor, and the individual preferences and expectations of the patient. Like those last two bits, the preferences and expectations of the patient. So if you don't want to take medications, me giving you medications does not work.
Right. You could argue based upon that definition, that's not evidence-based even.
I have patients that come in and all I've got up my sleeve left is a spinal cord stimulator.
Yeah.
And they're like, I don't want a spinal cord stimulator. I'm like, that's cool. No worries. Like, we'll aim to do X, Y, and Z.
Right.
And we forget that. And it's not just blind application of meta-analyses and randomized control trials.
Yeah. That's actually, I wasn't planning on sharing this story, but I will because it reminded me of that part of the decision-making process actually in my own journey towards the stimulator because of my previous life history, right? Going from medication to medication, way too much down the medication route of things post TBI. When I then developed CRPS, I didn't want me personally to go trying Cymbalta, Lyrica, gabapentin, right? Med after med after med. And obviously DRG stimulator is a last house on the block option and you don't do it unless you've exhausted other things, and I did sympathetic lumbar box. Those wore off. That was more so the progression, but that was a discussion that my doctor and I had too, where because of what I wanted and how I wanted to approach it, I didn't want to deal with a ton of side effects that had just completely changed who I was for so long. I would have rather learned to live with the challenges and the downside of the stimulator, which has been fairly challenging. Would someone else, make the same calculation? Maybe not. But for me, that was the best decision. And that was kind of the best combination of both worlds. The evidence was really good for DRG with CRPS. And it was what fit with my lifestyle, wanting to be otherwise active and not being reliant on medications the same way as I had been for so long.
And I think that even within the evidence for DRG stim, I think the data is 70% of patients will get a 50% decrease in their pain when compared to normal neuromodulate spinal cord stimulation. Okay, so that leaves you with 30% of people not getting a 50% decrease in pain. And a 50% decrease in pain over time doesn't end up being good enough from a stim
that alone.
I think like what we've discussed before, when I'm doing spinal cord stimulation, I want an 80% decrease in patients' pain because that in 12 months' time is, they're still happy at that point in time. We can talk more about how I want to see it go otherwise, but I think we'll see in the future. Cure is what I would like to see, but anyway, we can talk about that later.
Get to 100% eventually.
I think that we will get to a point at which we are able to take away the noxious feeling, like the ouch. The interesting thing that will happen from there is to see what happens with everything else around it. Like what happens with the anxiety, what happens with the depression.
The sensitization, the long-term effects. Yeah,
what happens with the catastrophizing, what happens with this, psychosocial stuff, what happens with the, all that when you take out the
ouch.
The ouch.
There's a whole lot less of that when you don't have the ouch. That's going to be my bet. But that's why it's hard to treat because until you can get rid of the ouch, you have to whittle it down in, all the other ways and ideally get closer and closer, to zero, which is what we want to help you do with this podcast as well. So I hope that helped.
It's a good point to sort of finish on a reflection for this in that, we are there's therapeutic limitations in everything. Even just this discussion about, well, can you take away the ouchy part of the pain? What are you going to get left with? And then how are you going to then manage that? And, at this point in time, what we do a lot of the time with pain is we try and take away minimize all the other stuff. Like the ouch stays.
Right.
But we can improve the depression and improve the catastrophe and improve the blah, 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 all that stuff, which is all really, really important. But everything's got its limitations. And I think that's really the key part of what we're trying to get across.
So what we hope this does for you too is help you adjust your expectations and understand why just because a treatment worked for someone else, it maybe doesn't work for you the same, or why one treatment won't necessarily take away all of your pain, why stimulators only take away 50%, why a pain program won't take away 100%, right? When you can start to see how pain works and why it's hard to treat and adjust your expectations to those pieces and the inherent limitations that we still have, it's just a more effective approach. And it's less demoralizing, I think, in some ways, when you're not constantly having your expectations not met. Because it's hard as a patient to keep trying thing after thing after thing And I'd rather not have these unrealistic expectations around those pieces.
I agree. Which is a great lead into the next podcast, which is going to be on how you set goals and like just push next, keep going. We'll sort of tie it all together.
All right. Thanks, guys. Appreciate it.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.